When we talk about cost, well, plerixafor, I think it was almost 4 times the number of people needed it. That's not an inexpensive addition to your regimen. And then the last thing is, I'm very torn with the infection risk with adding Dara. I mean, I think it's a great regimen. We put a lot of patients on the Griffin trial. There were a lot of respiratory infections. We ended up giving a lot of IVIG. And then I mentioned that at one of the ASTCT meetings and was immediately had stones thrown at me because in the whole choosing wisely, it's not the way we do it as myeloma doctors, right? And we tend to be much more liberal with our IVIG use, but that's not really the guidelines.
Yeah, well, I do agree about and exactly in our experience on Griffin was very, very similar to what you're describing. I think the IVIG is the important piece of the Dara addition, but, and again, clinical benefit I think is very clear. Other thoughts that the panel have before we move on?
I was just going to second what Emery was saying, was essentially that I think Dara, the outcomes it changes remarkably, and we should all be very happy with that. But again, the long-term use of Darzalex or Dara in these patients is that the hypogam is a different hypogam. Like I always think of patients as, we've always had hypogammaglobulinemia with all of our therapies, but now it's whether it's actually numerically a greater decrease or just functionally a greater decrease. So I'd say functionally these patients now are the same, but now they're starting to get infections, and so we just have to really be prepared with balancing those fantastic results we see by adding it. And I think the long-term part, really we're going to start learning about, because I think that's where we might see even better benefit, not just in these acute settings, which means that hypogam might be more important in our ability to protect our patients from infections, et cetera.
Just
be
to
really
pick up
critical
on that
for
briefly,
us.
there's no question that there is this increased infection signal, but I think that's the other message of Alcyon, right? So if the infection signal did not compromise in PFS, PFS2, or OS,
survival,
it puts it into context.
That's well said.
I do think it's important to think a little bit about duration of Dara if you're going to bring it up front. So, when I mentioned that our algorithm is RVD Dara for standard risk, we don't mean that with len until progression. We really give it for those first 4 cycles of therapy to deepen the response. And sort of theoretically an in vivo purge of the product when you collect. I don't know if that's true or not, but I'm curious. But we don't continue it in the post-transplant setting beyond that. So I think Griffin,
2 years in Griffin.
yeah, and even that's better than some of the other trials. What I worry about with Cassiopeia is that we're not going to get more information than the depth of response.
Yes, because of the maintenance, exactly.
Because the maintenance is randomized to Dara versus nothing. And if you look at the curves, they separate at the time that maintenance starts.
Yeah, no, it makes great sense. And I think, I completely agree with you, Sagar, about this Dara, the duration of Dara. What I liked when we designed Griffin was that it's every 2 months in that maintenance phase, which also opens the door.
They changed it.
Yeah, well, no. But the point is that even so, you go to the monthly schedule and so on. But the reality then becomes that, obviously when a relapse occurs, you can sort of recapitulate, and we'll come to that in a minute.